Okay, thanks for inviting me, but I think I beg your chairman, please move our session to the first date. I'm sorry about my hoarseness. Okay, my talk is about reverse. Okay, so I have to blame all of the first three surgeons. So the background of this talk, I think about which one is the gold standard for the irreparable massive cuff tear. I think no one can answer this question. Even the reverse also. Maybe Dr. Chanakan, maybe you will discuss with the balloon. The balloon is also said it's okay. The pain is good. Maybe the same price for the surgery. Maybe the cost of the surgery. This slide should be for the resident. The massive irreparable cuff tear. You have many options. For now, I think no single procedure that fit for all. You need to discuss with your patient, which for the best one. Also, the tendon transfer, the new one is lower trapezius, but the lower trapezius have a very good biomechanics, but they need a additional allograft for the transfer. For the direction of the lower trapezius is very good, but right now in Thailand or maybe in Southeast Asia there is no allograft like this. For all of the resident and surgeon, the first question you have to discuss with the patient is repair or could not repair. I use the first criteria. If you have a escape like this, or I never try to repair. After that, I use a examination like a uncontrolled leg side and the quarterly, and also the X-ray, and also the MRI at the retractable glenoid. That is my condition for irreparable. All of you should discuss about this. I think your surgeons or your teacher have different from me. I think it's non-consensus for now. Next, the partial cuff repair. The partial cuff repair is used to convert non-functional cuff to the functional cuff. You don't need to repair or complete repair. Just, however, it's just a case series. They said it's okay. But if you have this irreparable massive cuff tear with the recurrent shoulder dislocation, what would you do? My case, she came to me like she 71 years old, and she had a 5 times of dislocation. But the X-ray is shown no arthritis. But so I gave her 2 options. First, try partial repair, and next, if you would like to complete. If you would like to one-stop service, maybe reverse is your option. So she go for reverse. You see, the supra is go to the glenoid, and also the quarterly of the supraspinatus in infraspinatus is quarterly 4. I think no one can 100% recommend her for partial repair. I don't know. So the question, the result is not bad. She still get great. Come back to see me every. Right now is 4 years. The result is great. No dislocation for now. The function is great for us also, but the constant score is improved. The ASES score is improved, and also the SPARDI score. Next is tendon transfer, as Dr. Banchar says. Tendon transfer have some limitation. It's used in the young and also no arthritis. If you review to the systematic review, they have an improvement of the elevation. It's about 35 degrees of elevation, and the external rotation about 10. And also the power is never normal. So the LD transfer should be is for young, active, mild to moderate weakness without arthritis. Should be in non-smoker, and subscap and the deltoid should be intact. The best result is for the evidence is combined with reverse. Next is superior capsular reconstruction. Is the hot one. Maybe we call the Mihata procedure. They got like a 40 or 50 degree of elevation, and they can improve the acromial-humeral interval. But if you have an OA, maybe you could not say to your patient is good or not anyway. But you go to the reverse. The new data from the literature, it says also improve all of the pain score, the ASES score, constant score also is all improved. Next, the elevation is about 48 degrees. The external rotation is still -2. The longevity is on 10 years is about 73% of 70% of all the case is from the Christian Gerber. At 15 years, 73% the longevity, and at the 73 years at 10 years, 73% at 10 years, and 70% at 15 years for without reoperation. And how about my clinical outcome? Usually, for the arthropathy, the 70% is reversed. In my case, it's for the cuff tear arthropathy is about 20 cases for 8 years. The less age is about 64, and the follow-up is from 2 months to 92 months from now. The result is not bad. The forward elevation is from the 90 to 150. You got a 52 elevation gain, and also the external rotation. I got a 15 degree external rotation. All of the score is improved, comparable with the other series. The score is the same as me. The American shoulder is the same, and the constant score is maybe have a little bit better. Right, and also the elevation, they got a 48, but I got a 52. It's not bad for me. So that's why I felt reliable on that. The first case is the guys who have the massive cuff tear and have a pain, but he would like to do a weight training every day. So I got, you can try. Let's see. After 6 years, we will see it's loosening or not. But right now, it's still okay. 4 years is okay. He also have a weight something like this every day. He says it's okay. The X-ray is still okay also. no loosening of the glenoid. Sorry. The next case is my first case, 8 years ago. He came with a massive cuff there. I still had a, big notching, but the clinical result is good. The last 10 cases, that's no notching. It's my first case, but I know that's something that I learned, that maybe the big notching is not correlated with the clinical result. The left side is not good because he had a superior migration. Oh no, I think superior escape of his shoulder, but he's still good for now. He is still no pain, so I don't touch for the left side. So in conclusion, for all of you, no non-procedure that fit for all. You need to discuss with your patient. The partial cuff repair is the option for low demand, maybe 70-year-old patient that have an irreparable cuff tear. The LD transfer you gain for the review of literature, you got a 35 degree of elevation and 10 degree of external rotation. It's good for young and mild to moderate OA, and no proximal migration, and the subscap and deltoid should be intact. The SCR is, you got a 64 degree of elevation, but it's ideal for the young, no OA, and no severe cuff muscle atrophy. For the reverse, for my series, I think I have a reliable elevation about 52 degrees for now, and 13 degree external rotation in patient that the age over than 60-year-old. I had a significant improve in SPARI, ASES, and constant score. It's good for the moderate to advanced OA with or without pseudo-paralysis. Even recurrent dislocation maybe is an option. So right now it's more extended indications for now. Not only me that perform in the patient without arthritis, also the Franco use also. So
okay, thank you. Thank you.